Welcome, everybody. And today we are going to be talking about TeleStroke. I'm so excited to have Dr. Burton Tabaac with us. He's the medical director at the Comprehensive Stroke Center at Reno Health. He's also an assistant professor of neurology at the University of Nevada, Reno. So he's going to be talking to us about TeleStroke. TeleStroke, is interesting to me because like telepsychiatry, it was one of the early adopters of telehealth. Dr. Tabaac, if you could share with us, how it is that you initially got involved and what your day-to-day work is like.
Well, first, I just want to thank you for having me, Ray. It's an honor to be here. And my responsibility as the director of the Comprehensive Stroke Center here is to guide acute care treatment of stroke. We have a very large encatchment area for our facility, and so the best way to have neurology interface with the rural patient population within our state and parts of California is via telestroke and telemedicine presence. We have a service line agreement with several outlying hospitals. And when a patient presents with stroke-like symptoms, if they are within the first 4.5 hours from the symptom onset presenting to medical attention, then they are a candidate for intervention and potential treatment with a clot-busting medication called TPA. This decision is best made in close consultation and coordination with a neurologist, and ideally a vascular specialized neurologist. So we are able to offer that service, see the patient, get an examination, and then while we have the hands on site to help facilitate that examination, we are able to make a decision in coordination with imaging whether or not the patient's going to receive treatment.
Oh, okay. Yeah. So use a lot of telehealth aspects rather than just over the phone. When I was in college, I worked on an ambulance. So I know that when someone was having a stroke, it's like, man, having a doc to consult with and being able to administer those meds right away was like absolutely vital. It's like when there's a stroke going on, you just want to get them to the ER as soon as possible to get the meds that they need. So that's just my limited experience of that kind of stuff. But I would imagine that a lot of your work would be done over the phone and with ambulances. Does that happen?
Well, as you note, time is brain, and every minute counts. There are other facilities that do have a construct in place where they can have that phone call, and what they're relying on is the examination of the provider on the other end of the phone call. The benefit of having a telepresence is for me to actually lay eyes on the patient and maybe pick up some subtle exam findings that might be missed to an untrained eye.
Okay.
So, for example, a facial droop may not overtly present with what we see in the media and what's shown in even the medical literature. It may be as subtle as flattening of this nasolabial fold. If we are looking for a weakness, a patient might demonstrate that weakness with just subtle pronation. We call it pronator drift. It's an upper motor neuron pattern of weakness that might be missed if we're doing an NIH stroke scale with palms down. So by adding that extra element of neurological expertise, that's something, just as you can see on this video here, it's something that I would be able to see from having that telestroke interaction.
Yeah. And when you say with the untrained eye, would you say that that's even the case with a general practitioner, an ER doc, that doesn't specialize in stroke?
That's a great question. And I think that there's a lot of value and expertise that a specialist or a generalist can offer. They really are a jack of all trades and have to know a little bit about a mass amount of information about every organ and body part. So by by being a neurologist, I have the luxury of just focusing on the brain, central and peripheral nervous system. And so I have the time to really delve in and look for additional examination maneuvers that aren't part of the NIH stroke scale, classically taught to emergency medicine providers or generalists.
Yeah. I mean, these are questions that are, popping up in my mind in terms of how this works. So there's different qualities of camera. Some can zoom in great. Some you have far sight control over, so you can, control the camera yourself in terms of pan, tilt, zoom, etc. Not all sites, locations probably have that. How much does that come into play? You probably have to also coach the person on the other end of, hey, have them move in closer to the camera or move further away from the camera if they don't have a high quality camera that you at the other end, can control. What does that look like, and the variety of that look like?
I'm glad you mentioned that, because I do notice that there is variability from site to site, depending on what sort of equipment is implemented. But even more than the equipment itself, I would say that the experience and the quality of the console is more directly related to the technician on the other end.
Okay.
Having experience to know what I'm looking for, maneuvering the patient in certain ways. So if the training from the technician's perspective is strong, that can often offset any lapse or difficulty from a technological perspective.
Yeah, and part of that training of the technician would be being aware of probably the lighting and what's actually being shown on the camera, right?
Absolutely.
And knowing how to utilize that.
Sure.
Yeah. Yeah. Okay. Yeah. Because if the camera's static, right, where you don't have control over it, like right now, I can still back up, make sure that you can see me okay, and you probably have a large monitor, right?
I do.
So even though I'm far back, as long as it's high definition, you can get a good view. Now, the fact that you're watching movement and not static images, you also need that good internet speed, right?
Absolutely. And this sort of calls back to the question I posed as it pertains to what is the benefit of having an added telepresence when a lot of the examination is able to be dictated over the phone. And the more information we have, the better the quality and the clarity. I think that just adds to the confidence in the clinical impression. Mm-hmm. However, that's not to say we can't offer some sort of guidance and recommendation in the absence of having a crystal clear picture.
Mm-hmm. Yeah, and getting the imaging, that's probably very helpful to you. It's great with technology. They just send over the imaging to you. And now with the video, it's probably always live, right? It's probably not asynchronous where they do a video and then send you the recording, because this is emergency kind of work, right? It's the here and now.
Exactly. We are making these decisions live in real time, and often we will be able to, I would say we always have the ability to then receive those images through PACS or another site where radiology images are able to be uploaded into our system for review.
This is not my field. I really don't know, about how to assess stroke other than working on the ambulance and stuff. But just knowing the technology that's out there, I know that dermatologists really appreciate the camera because they use cameras that detect the temperature. Like the cameras can see the subtle differences in coloring on the skin that they can't even see with the naked eye. They can even see the pulse through the skin, because of the coloring. Like they really appreciate. I don't know. Does that impact the coloring of the skin? Any of that kind of stuff impact your assessments or no?
So what you're referring to are the probes that can be applied via the technology, where we have devices that connect directly to the telehealth equipment, and we can get those magnified views. However, from a stroke perspective, from a vascular neurological perspective, I am more keen to note crude findings, such as an arm drift,
Uh-huh.
In fact, we have a mnemonic that I think might be helpful for your viewers. The signs to recognize a stroke, and that mnemonic is B fast. The
Okay.
B stands for balance. The E stands for eyes, and the I abnormalities, whether there's a deviation one way or another. The F stands for facial droop.
Uh-huh.
The A stands for arm drift. The S is speech, any sort of slurring or difficulty in word finding, which we call aphasia. And then the T is time, to remind people not to wait and to call 911.
Yeah. Okay. Excellent. And telestroke has been going on for, well, they've been using the phone forever, right? I mean, you tell me, what's the history? When did, because what I'm thinking is I assume there's probably solid research on the impact of telestroke, having an expert on hand to help with the assessing and treatment plan.
Yes, the AHA, American Heart Association, and American Stroke Association regularly release guidelines as it pertains to acute ischemic stroke, even as it pertains to pre-hospital care and acute intervention. And there are guidelines that show the evidence and the level of evidence for implementing telestroke and telepresence into practice, and that's nationwide standards, and that can be looked up for free on the internet.
Mm-hmm. Yeah. Another thing this points out, yeah. So it shows that it's the telestroke, really had a big impact on the results.
I think that having telestroke and telepresence, telehealth, affords the availability of resources that might be constrained or constricted for a portion of the population that might not otherwise have access to said services.
Mm-hmm. Mm-hmm. Yeah, because if you're in a small hospital, right, having a specialist in stroke is probably difficult, right? I mean,
and there is a national shortage of not just physicians, but of neurologists in particular. So having this technology, I think, is extremely valuable.
Mm-hmm. Yeah. There was another question I had, and it just popped out of my head, but
follow my finger with your eyes.
Yeah, right. make sure I'm okay. Yeah. Is there anything else that our listeners, viewers should be aware of that would be helpful?
I think that it's important to ask what sort of telehealth services are offered by your local facility. Mm-hmm. And just know that as it pertains to stroke, to know to recognize those signs and to not wait. If when in doubt, call 911 because time is brain. And if you have any further questions or interests, I would appreciate if you could provide the information to our website where they can submit questions directly. And I just want to thank you again for your time today. This was great, and I enjoyed chatting with you.
Yeah, you're very welcome. And I think that's something that's very important to our listeners is those that do work with stroke patients in terms of where to get resources, information, if they want to onboard telestroke services for their hospital system, where to get started. So connecting with you would be a great place to go. You could probably point them in the right direction. Another thing I want to mention is, a lot of physicians, organizations, regulation kind of pushes back with telehealth, saying, "Oh, well, you can't really do an adequate physical exam, so therefore you have to have an initial session, visit with the patient on site because of that physical exam." But this is a demonstration where you're doing a physical exam remotely. But you have someone on the other end, helping you with that. And it sounds like you can coach that technician, the telepresenter, telefacilitator on the other end. You can help coach them through what it is that you're needing to be able to adequately do the physical exam.
And what I would say to that is I think that it likely varies from place to place based on certain policies, but the difference is the acuity of care that comes with stroke, and the benefits clearly outweigh risk. And so to have that expertise and being able to provide a treatment that can only be given within a certain window is strikingly valuable. And so I think that the general public is able to agree and see that there's value in that. And whether or not that extrapolates to non-urgent consultation is yet to be determined.
Yeah. And what about follow-up care? Are you involved in the follow-up care with patients through TeleStroke?
So there are capabilities at other facilities to have follow-up visits where after that initial decision is made, there is additional value in having a neurologist to determine what is the underlying cause of that stroke, because it's not one single disease. Stroke can be caused by a variety of underlying causes, and whether that's large vessel disease of atherosclerosis in the neck or atrial fibrillation and a clot coming from the heart. Unfortunately, we don't have the current capability to follow up on a day-to-day basis on outlying facilities, because we have such a high census and volume of an acuity of patient care here. But I think that you note an opportunity for further expansion.
Yeah, excellent. Yeah, and just to clarify, so are you doing telestroke like with paramedics on the ambulance? And if not you, I know some organizations do that.
Sure. Right? And you're right, that capability is implemented in other parts of the country. The way that my practice implements telestroke is always with an on-site emergency room, hospital setting, where the equipment is established and in place.
Yeah, excellent. Yeah, well, Dr. Burton Tabaac, I really appreciate it. It's been very helpful. I'm sure it's very helpful to all our listeners, and they can contact you for more help and support and direction in terms of where to get connected to bring these services on site for their facilities. So thanks a lot. Appreciate it.
Thank you again for your time. Stay well.
Thanks.